Good morning, good afternoon, and good evening to our distinguished speakers, chairs, and the audiences in different parts of the world. Today is a very special day for us, and we are hosting our 100th episode of the ACNS webinar. This month completes our one-year journey of online education, and hence is also termed the anniversary edition. We are extremely thankful to Professor Yoko Kato, the president of the ACNS, and Professor Shubin, whose vision and unconditional support enabled us to achieve this feat. We are extremely thankful to both of them for coming here today and bless this occasion. For this very special occasion, we have two doyens of neurosurgery and very special guests who have joined us today. A very special welcome to Professor Madjid Samii, who is the founder, president of the International Neuroscience Institute, whose services to world neurosurgery was extended to the rest of the world with two more internationally acclaimed neuroscience institutes that came into existence, one in Beijing and another one in Tehran. Professor Madjid Samii, rightly termed as the Shahenshah of the neurosurgery a short while ago by Professor Anil Nanda, rightly deserves this term. Regarding our chair, Professor Anil Nanda is the world-renowned neurosurgeon and is a Peter W. Carmel, MD, Chair of Neurological Surgery, Rutgers University, Robert Wood Johnson Medical School, Rutgers, New Jersey Medical School, USA. Professor Nanda was the past chairman, secretary, and the president of the North American Skull-Base Society, and is an integral part of the ACNS, CNS, and WFNS. He has won several awards and honors during his vast illustrious career for the contribution to neurosurgery. His scholarly articles includes 500 manuscripts and 60 book chapters and 4 textbooks. He has been invited as a guest speaker on more than 100 occasions, and he also features on the editorial board of several leading journals. He has been a mentor to neurosurgery residents from all over the world, and we are extremely thankful to him for accepting our invitation to chair today's webinar. On behalf of the Education Committee of the ACNS, President Professor Yoko Kato, we sincerely welcome everybody to this online platform of ACNS webinars. Dr. Liu Boon Seng is my co-host for today. A warm welcome to all the distinguished guests, Professor Suresh Nair, Professor Shubin, and all others who have joined us all over the world. With that short introduction, I'd like to hand over this platform to Professor Anil Nanda.
It's a real honor to introduce Professor Samii. I think, no one in the world of neurosurgery has acquired the stature and everything that he's done, but I want to acknowledge the Asian Congress of Neurological Surgeons. I'm very humbled to introduce somebody like a giant like Professor Samii. He's somebody that's an inspiration for all of us across the world. And I want to thank the Asian Congress for all the work they've done educationally across the globe with Dr. Kano's founding vision and Professor Kato. Many of you will hear in 2-3 months that Professor Kato got the Lifetime Recognition Award from the AANS, Global Neurosurgery, of all the good she does across the globe and the amount of microscopes she's bought and what she's done. She's been an amazing inspirational figure. Madjid Samii really needs no introduction. He is one of the legends of neurosurgery. They have a wonderful saying about literature. They say, Shakespeare, there is Dante, there is no third. Or they say, there is Shakespeare, there is Cervantes, there is no third. And I would say today, there is Harvey Cushing, there is Madjid Samii, there is no third. He has been a great mentor. My own mentor, Peter Janetta, worked with him. And I want to acknowledge his wonderful wife, Mashir, who's so good. I always tell people behind a great man, there's a great woman. His wonderful family, Amir, is someone we all love. So thank you for being with us. But I also think he represents, he is like Da Vinci. Da Vinci was called the Homo Universale, sort of a genius in what he did and whatever he touched, and was a mentor. And the Italian Castigliano talked about sprezzatura, which means the art of effortless mastery. I was once blessed to have scrubbed an acoustic with Professor Samii in Pittsburgh, and it was like watching a symphony. He was just going. I'm like, boom, boom, boom. It was all out. I'm like, oh, Anil, this is. So I always tell residents that was one of the great experiences of my life. He's just a master surgeon, a master mentor. And above all, he's an affectionate human being. I always feel of Professor Samii like family. And I think thousands of neurosurgeons across the globe feel that he is part of their family because we've all benefited so much from him. So without much further ado, I introduce the rock star, the Beyonce, the Roger Federer, the expert of everything in neurosurgery, Professor Madjid Samii.
So just I want to say thank you very much for the Madjid Samii. Of course, he's the real teacher for all of us. And we are very, very honored to have you tonight for us Japanese. So today's the webinar, the educational event. So my backside is the few words from him. So he gave us so many, the very important. Can you see my, sorry, I cannot see. So such as the honest, as a neurosurgeon, so the honest, the tolerance, and example, or transparent, so on. He gave us so many, the very, very important words, especially for young doctors. And besides these things, just upcoming, the June 19th is his birthday. So just we all wishing you the happiness on your birthday and always. So just everybody join me, please. Can you hear? Happy birthday, Madjid. Thank you very much for tonight, the joining for all of us. Thank you.
Thank you so much for that.
Thank you.
Kind words. We'll go into our most awaited lecture by Professor Madjid Samii.
My dear Anil, my dear Yoko, I shame myself listening to you both. I think I am a very simple and very normal, usual person. Nothing is superlative in my life. I have only tried to serve and to share my thought and my knowledge with my colleagues around the world. And that was my personal habit. And as I was a little child in the school, when I learned something and I had the feeling the other people, the other classmates, they didn't understand or it was difficult for them. I was unhappy and tried to distribute that what I have learned to all my friends in the class at the school. And when they had it and I knew that they are now able to discuss about the topic which we have, and I was so happy you cannot imagine. This is something follow me through all my life, even today. You cannot imagine that when I make a round in the hospital and I have young people around me, for each case, I try to describe for them why this case is important. So, and probably the key point was that I have never given up to do this in all my life. This is for just short response to your very, very kind and nice words you said to my person. Today, we have, of course, I must say that Yoko Kato and Nanda both are absolutely belong to the toppest neurosurgeon in our time. In every sense, not only for neurosurgical ability, but also in their worldwide contribution for neurosurgery. This is without any doubt. And therefore, I thank you both for your contribution and also your achievement. And we all respect you both in all over the world. Today, I have decided to talk about brain surgery today. I believe this is a very important topic and a topic which we, in the next generation, even we can continue to develop this, because brain is a secret that has not discovered. But Anil would not forgive me if I wouldn't start a little bit with a history because he's master of history. I am already afraid to talk about history when he is listening. But nevertheless, about the history of neurosurgery, I can say some words that are pioneers of the 20th century, like Horsley, Krauss, Cushing, and Förster. They have started without having any support, technical support, and really still I admire these people that they were able to do it. The revolution in the diagnostic came by William Conrad Röntgen, as you know, discovered in Germany, in Würzburg, on 8 November 1895, the X-ray. And in 1901, he received the first Nobel Prize for Physics. Unfortunately, it didn't help us at that time because we could see only the skull, but not the brain inside. And Walter Dandy was the man who then started to do the first options for our diagnostic and did the error study in ventricle and later the Monitz, who then introduced the cerebral angiography. And I personally, in early 84, I heard that because the planoencephalography, there was so much overlapping, we could only expose the ventricular system better, but not the cistern, and so that was not possible to have a very good exposure because of overlapping. And then I heard about the Shiro in the United States and Wackenheim in France, about we could use tomography when we do the air study. And we had a wonderful polycyclic tomography machine at the University of Mainz. And I took that and it started after every encephalography to use this tomography. And then I found fantastic pictures with millimeter cuts of brain. And you can see here, this is, for example, even in increased intracranial pressure where air study was not allowed, I found a way first make a intraventricular drainage, lateral ventricle, and then I take out the pressure and I can give the lumbar air. And this is the first case ever in the medicine that we could expose a membrane in aqueduct as a cause of a hydrocephalus. That I was so proud, you cannot imagine. And then, of course, I found many other diseases, and you can see that that is from 1964-5. You see how beautiful the cerebellum here and four ventricular aqueduct and lamina quadrigemina and all the corpus callosum and so on. And I was so proud about that. And that was my thesis. I did 800 cases of planoencephalomography and then published, that was my thesis, planoencephalomography, for become associate professor at the University of Mainz. And but immediately I published the book, then was computer tomography introduced, and later magnetic resonance imaging. But there was no problem. I understood that the time is changed. The planoencephalography belongs to the history. But in the same time, I have, of course, started to use microscope. And in the last 60 years of microsurgery and 40 years endoscopic support, neurosurgery has been changed a lot. And I was happy that I was one of the first who started. I started 1966 microscope for neurosurgery. With the help of microscope and endoscope, every region at that time of the skull base becomes accessible. And that was the reason And I had, of course, enormous experiences in peripheral nerves and also vessels, so that the skull-based surgery was born in that time. Why I am telling you? Because the skull-based surgery at that time had more interest for us because we could help many patients with tumors at the skull base that he had no solution because of the was not accessible and was very risky. And you see that in 1979, after having more than 10 years experiences with my late ENT colleagues, Professor Graf and the wonderful anatomist, Professor Lang, we have started the first ever course for training other colleagues in the world on beauty of skull-based surgery. In this course, you can see the first participant and coming from different countries of Europe. And you see, this is the announcement of the first course worldwide for the first time. 10 years later, our experience, Wolfgang Graf and myself, we have done 20 years experience, described that in the book Surgery of the Skull Base, and we have written an interdisciplinary approach because I wanted to really to stimulate my colleagues in all over the world that ENT and neurosurgeon, maxillofacial, even ophthalmologists, neuroradiologists, anatomists, they should work together to find quicker and better the solution for approaches and for the, but this was, of course, we were very enthusiastic. And you can see also here a book which I published in '92 with my pupil, Professor Knoss, who had them become later the chair of the University of Vienna, about, at that time, approaches to no man's land. Clivus was a big problem, and we have described in this book all different approaches. But despite all such a development of a skull base surgery, the outcome of brain surgery was for a long time not predictable. With advancement in technology, this provided permanently more information, particularly with MRI images. We could expose better and better the location of the lesion, and at the same time, also the function. And when we had the good location and good function, and we could, of course, for brain surgery, slowly improve the brain surgery with preservation and improvement of the function. I would say, in summary, we had the goal, understand the brain. Understand the brain, we had learned very quickly that the human brain has enormous variation. I must say today, we have probably on the earth, when we have 7 billion people, we have 7 billion different brains. I am convinced about this statement because more and more when we make the brain mapping, we see so many different between one individual to the other. And this is something that makes the situation more interesting. And therefore, the introduction of brain mapping, as you see, is the map of the world, has the brain mapping has started slowly to influence the brain surgery. And what is brain mapping? Brain mapping, when we are talking, is nothing else of anatomical and functional exposure of the brain within the region of interest, also there where we are expecting the pathology. With brain mapping, we can make a better surgical plan, trying to avoid any possible complications. The brain mapping has 3 pillars. One is the quality of neuroimaging, quality of neural monitoring and the quality of neural navigation. This is something that I'm going to go with you through this journey. For this reason, in the, I would say, middle 90s, I had the idea to create a center in which all these possibilities of technology to include inside of this house. And as we had the Expo 2000, that I had done the idea to build this in the shape of the brain. And in this, we had the first 3 Tesla in Europe included in the technological setup of this center. And it started first with the corticography for anatomical exposure of the region. But we have seen corticography is not enough, because when we go deeper into the brain, we need then also the teratography, we need the fibers. What happened through the, so that with this, we have started to extend our knowledge deeper and deeper in the brain. This is the imaging series we have now. We have introduced at that time in Neuroscience Institute in Hanover, from CT to PETs, as you see. But the problem that I said at that time, we need always the data reduction, but there are so many images that every patient can have, and it makes the situation that easier. But nevertheless, we can get more and more. You know, we have then created in our house a computer graphic workstation. This computer graphic workstation was that our resident, our associate, every day they took the cases and tried to simulate the operations for the next days and try to have some idea, and we discussed all together. And this was also very important. Important was also that every case had for the craniotomy and navigation system. You can see here a cut of the first level of our center, which has is just only neuroradiology here. You can have 1 Tesla, MRI, 3 Tesla, and angio suite, and so. And we had 6 operating theater, which were one was brain suite with intraoperative MR, a stereotactic suite, and endoscopic suite, and angiography suite. So we could do that intraoperative angiography and embolization. And we had also still mobile systems of neuronavigation, endoscope, neuro monitoring on C-arm, etc., for all 6 operating theater. That was also available, and we could use to perform for each cases all the diagnostic on brain mapping for a case. But what we have learned is that the importance of not only the arterial supply, even more important are the venous drainages, particularly to the superior sagittal sinus. And also, this was not only that by sacrificing we could have a hemorrhage, but also this venous drainage on the surface of the brain could be, during the surgery, a wonderful guidelines. Also, as there are very, very markers that we can take them as landmark and then orient us, a good orientation to reach your target. You can see, for example, here, this meningioma of the parasagittal on both sides. You see the venous drainage anterior or posterior of this. And so that when we do the craniotomy, we have, of course, to take care that the preserve for the brain, we have to preserve the venous drainage. On the other side, when we have the vis venotrachea here, we know that the tumor is behind that. And that is what I believe is also very nice. The other thing which we have learned from case to case, that all for us so-called eloquent area. I don't like this word, but I have to say, for example, with a motor function, on sensory function, speech centers, and so we have seen that they can display, it can move from one place to the other, and therefore we must be always careful to expose them around the pathology to avoid to destroy them. For me personally, for a long time, it was difficult to distinguish between displacement of these important structures or it is reorganization of the function. And I look at this case, it's a very interesting case. If you see the unaffected hand here, that is here, this area, but the other side is the tumor. But when we make the functional MRI for affected hand, you see that the hand is divided with this tumor, one to the right side, one to the midline. Midline is also the place that normally we have the leg, and so that this is a very good example. But we will see then more examples. The other thing that we have learned, it is not only important to preserve, and probably in future, more and more, we have to take into consideration the cognitive condition of the patient, particularly also the memory, which started in the hippocampus and distributed in different areas. And we have to learn different systems. In the meantime, we have my colleague, neurologist, Professor Prof.Madjid, who has a lot of papers in Nature, and he's working on exposure of the different existing systems in the brain. I believe there are thousands of different systems that we don't know. This is, for example, an example of the so-called medial limbic circuit, which starts with the hippocampus and goes to fornix and to mammillary bodies and through the mammillothalamic tract to anterior thalamus part, and from that back to the cingulate gyrus to hippocampus. This is something that just have one example, but I tell you, in the next probably 10 years, we will have many such systems that are important to consider for our surgical strategy and philosophy. Here you can see, for example, between Wernicke and Broca fasciculus arcuatus. And of course, when we destroy in between this system, then the patient can, despite of preservation of Wernicke, and so they can have done speech problem. And the other thing here, you can see the fornix. The fornix is very important for our short memories, and we have to take care of it, and this is very good. The next point, which is very important, is neuromonitoring. Neuromonitoring in neurosurgery, I have started, first of all, we should know that Luigi Galvani's work in Bologna in 1780, I don't want to go to the details. Later, Alexander Volta used his experiences and then created the neuromonitoring. I have started already in 70s as I was busy with acoustic neuronome and for facial nerve and cochlear nerve. And from that time, we have started to improve this. And we have later, one of my pupil, Professor Cordola Matis, he has created the near field monitoring to the brainstem, that the speed of the reaction was 10 times higher and the waves also larger, so that we could quicker understand that something is wrong now by manipulation of the tumor with the hearing. So that this has also changed a lot. And we use then more and more done cortical, also, not only cortical stimulation, but also in brainstem. For example, in fourth ventricle, in the floor of the fourth ventricle, very important is the facial and also abducens nerve, and also the caudal cranial nerves, and so on, more and more. These are great help for preservation of the function. Here, as you see here in cavernoma of the pons, that we can, before we enter into the floor of the ventricle, we stimulate here, and then we find the way, which way is not, we can save the facial or abducens nerve when we enter that here to expose this and the tumor here. Another cases of pontomesencephalic cavernoma, which I operated from temporal approach, lateral approach, as you see here. They all need so local stimulation to be sure that you are not destroying any function. The neural navigation is, of course, very, very important, but unfortunately, they can be used for craniotomy precisely. I remember already 50 years a year ago, or even 40 years ago, when the assistant, the resident made craniotomy, sometimes it was 3 centimeters at the different place where the pathology was. But with the neural navigation, it is the maximally 1-2 millimeter. We have a difference of the planning of the craniotomy. But after opening of the dura, of course, we have no chance of using, and we should avoid to use it because it is dangerous to have a wrong position of the brain with navigation, and therefore the navigation system work when you have intraoperative MRI. I will talk about that shortly, and that you can make immediately neo images, and then you can do it. Now I show you one of the first cases that brain mapping changed my personal feeling for the brain surgery. Is this 14 years old girl who was the daughter of one of our anesthesiologists that we knew him, had then 3 months before generalized seizure, but no neurological deficit. But as I saw this MRI at that time, this is almost 20 years ago, I saw that I was afraid, and I said, I cannot go and operate this case and remove this central region and create a hemiparesis of the girl. But we did that. That was one of the first very intensive neural navigation, neuro mapping. And you can see here what happened. When you see that the tumor was on the right side, and here the motor cortex was pushed anteriorly where the tumor exactly was in this area. And therefore, I have decided to go on and then operate this tumor. And this is, of course, one of the first experiences I had with this displacement of the area. And you see that we expose also the venous drainage in the brain mapping, while we believe it is very, very important. This is the operative case. As you see, we have exposed this venous drainage to superior sagittal sinus, and this as well. And you can see very well that the tumor is just under this vein or anterior to this vein. And here you can see that the motor cortex is just under this another venous drainage. So, but despite of this fact, we use the cortical stimulation to be sure. And in fact, we could see respond when we have stimulate this area. And that was the tumor. And under this venous drainage. So that I have done this surgery and I have removed the tumor. And as you see here, the tumor was completely removed. And here was the motor cortex, which was moved anteriorly. this made me very, very happy, this case, so that I have started to accept every tumor which were in. So that is also the leg of this girl, had no problem of the surgery. All tumors in eloquent areas or in speech center, left side, and there was no different for me, left side or right side. In using, of course, intraoperative MRI, it makes it easier that intraoperatively we could, after opening of the dura, we can then make new images, and this shifting can be corrected. And that is, we have here in our system, we had the first open wide bore, 1.5 Tesla MRI for therapeutic use. That was the first one in Europe. And it was connected to a navigation system, brain lab, the same, and also a navigation macroscope, both together. So that this is the view to the brain suite, and that is the control room, so that we can hear then, this is with a computer graphic station, we can hear before starting to do a MRI, and then we can then plan here the surgery. That is the position of surgeon here outside of the circle, so that we can use any instrument here. And then we turn the head into the magnetic resonance. And this is an example of a 9-year-old patient with astrocytoma, pilocytic astrocytoma. He had a biopsy in other country and had severe left hemiparesis. And we have done the here brain mapping. We have seen that the pyramidal system is only compressed, but it is not interrupted. So anterior to this, so that it was very simple for us to make a decision and go to this tumor from this approach. You can see here, and then try to remove the tumor. Here you see the first intraoperative MR, which shows here is still some tumor, and here you can see the tumor is completely removed. And here, 13 days after surgery, the entire shifting is changed, and you see the midline is a good arm, and the pyramidal system went back, and this patient has, of course, wonderful recovery of the paresis. Interesting is that when the pyramidal system is displaced by the tumor, when the tumor completely is removed, but it is not changed, as is infiltrated, then when the tumor is removed, you can see how beautiful the fibers come back. This is an interesting case, as you see here. This is a tumor occipital region. You can see the optic pathway here going to central vision of the occipital lobe. But on the side, when the tumor is, we cannot expose it by the DTI. And this is the removal of the tumor. And after removal of the tumor, you can see immediately that is before removal, we don't see the optic pathway. After removal, you see the optic pathway. Intraoperatively, we could then expose this and see that everything is okay. This is, believe me, for me, the most challenging and most important experience I had during all the time, because I could never believe that the BRCA, this is a recurrence astrocytoma by a 25-year-old girl. And of course, she was language interpret for 5 languages. Of course, nobody wanted to operate this case because her job was talking, and we did, but the brain mapping and we were surprised that Broca, which we are all expecting in the gyrus frontalis inferior, was moved into the gyrus temporalis inferior. Can you imagine? This is something that I could never believe that happened. And then I have decided to do surgery, but I was absolutely convinced my approach must be frontal. I have to come here, first clean this part, and from here then remove the other part in order to preserve this part of temporal lobe which left for the Broca. So this happened, and you can see this is the first intraoperative MR, and here you can see then the middle cerebral arteries, and then we have done removed the next part, as you can see here, and you see here also the optic nerve, and here is the speech center, which we have temporal lobe, what we have preserved. And here you can see this girl, 25 years, with her father, and here the complete tumor removal, again, intraoperative MR. This is, of course, something that I can say, this is not a displacement, this is the reorganization of the Broca in other gyrus. And this is also a challenging case, as you see here, because the middle cerebral artery is inside of this tumor, but here is the Broca. You can see here is the Broca. And of course, when you have to remove this tumor completely, you have to count that here speech can be involved. I speak always in these cases with the patient and say, look, you can have after surgery temporary speech problem, but when we, during the surgery, preserve the area of the Broca or Wernicke, then here is the Wernicke. You can see that. That is the Wernicke, and this time here is a little bit far away, and and the pathway between both tractus arcuatus here is also behind of the tumor. Finally, we have decided to do the surgery, and you see the tumor is removed, and I preserved entire branches of the middle cerebral artery. And here is the patient, and you see now it is about 2 weeks after surgery, no paresis, and also here you can see it in the speech.
Where are you from? I came from Uzbekistan, from Central
And
Asia.
he was, after 2 weeks, he has, the first week he has problem of talking.
I found in the
He was a priest.
27th of December, because I'm a pastor of church, and I preach, and I didn't could read the book, and I could everything to do, but I couldn't reach to do. And next day I went to check, and I found
yeah, perfect. Okay. So now is how long the surgery?
I think from the found what I was and the surgery, there was 1 month.
Okay, so now it's 20 days that you have the surgery?
Yes. 20 days after surgery, he's talking now without having one single
to finish
problem, and also no paresis. So when we look at the intraoperative MR, we have in the meantime 2,000 cases, and the number of the high grade is much more than the low grade glioma. And looking at this is 25% were low grade and 75 high grade glioma. That is a statistic of the first 1,000 cases we have done. And with DTI, functional MRI, DTI on functional MRI, and all the technique which was necessary to do. But The outcome was, in these cases, unchanged or improved in 91.2%, and transitory deterioration was 7.9%, and 0.9% was a permanent deterioration. And if we look in the high grade, that was a low grade, that is high grade was 89%, unchanged, on 7.9% was as a transitory, but 2.2% permanent. That is the result. I will now talk about one of the most important, I would say, things which I have personally slowly developed for the brain surgery, and it's had a history, goes back almost to 40 years ago. I had the idea that the salty of the brain, because of viscoelasticity of the brain, are very narrow. But if slowly we take the time, we open a sulcus, we will be able to extend this way to at least few millimeters up to perhaps 1 centimeter. And with this, we can remove some tumor which are located deep into the brain. And in the same time, we can preserve the eloquent areas, the fibers, and everything which are around this sulcus. And I will show you some example of that. This is one 21 years old medical student he came in the first year of university. He had 2 seizures, a numbness in the right hand and fingers. At that time, you can see there was no navigation system, no brain mapping for 40 years. I had the idea when I saw this MRI, you see the quality of MRI of 40 years ago. I saw this street here, and if you look in the other one, there's a street. And at that time, I had the idea why I cannot go through this street and here reach this cavernome and remove it. But how I come to this sulcus, that was really very important, without on the left side to destroy any part of the brain. I had the idea, I will take the strotactic frame and I use it, and I say, okay, the pointer, also the needle of a strotactic brain will show me exactly the position of the sulcus. Then we did around that a craniotomy, and then I control it with ultrasound, you can see. And then I found here the sulcus, which we have seen in MRI. And then I opened the sulcus, and immediately in the depth I have reached down this cavernoma, remove it. And now you see post-operative pathway, which I have removed. The girl recovered very well. And here, an Italian girl, and without any paresis, she studied medicine, and she married and has 3 children. Now she must be close to 60 years old. This was done without any brain mapping, this idea was in my brain. As we have started to have the navigation system and brain mapping, and here is an example of 28 years old lawyer, and they had recurrent episode of headache this cavernoma was of bleeding. All my colleagues have refused to operate this lawyer on the left side. And I saw this sulcus and I said, oh, this sulcus is a good chance. Let us make a brain mapping, which we have done. And unfortunately, we could localize the Broca and also Wernicke. And we have seen also venectasia in connection with the cavernoma. To the vein of Lae here, as you see here, and that is the Broca, that is the Wernicke, that is the cavernoma, and this is the sulcus. And now you can see here. the brain mapping, you can see here, wonderful, very well. That is the Broca, Wernicke, and this is a venous anomaly on both sides. So in between, we had the sulcus so that we could preserve the both sides, both Broca and sulcus, and enter into the pathology. That is this what you can see here, and that was the exposure, and that was the sulcus. You can see this venectacy here, which is very dangerous. If you open that, you get a hemorrhage of the entire temporal lobe, and after removal of this here, you see very nicely this can be removed, and this is the way. Here is Broca, here is Wernicke, here is the venectacy, what we have seen in things, and the two these could be removed. This is that is another case, very small cavernoma under the motor cortex, but no sulcus here. But I decided to take laterally the sulcus and try to remove this cavernoma, which had created some in the leg of this young 19 years old girl. And you can see here that laterally I opened then the this little incision of the brain. This is a thalamic glioma from Russia, from Moscow, and my good friend Sasha Konovalov at that time called me and said, this is very risky case. Have you any idea? This is a young, nice lady, is a doctor, 3 children, and they came to me. As I saw, I said, it is almost impossible. This is all thalamus here. But as I have looked here, I saw there is some place here that it is not connected with the thalamus. And I said, when I come from contralateral side, then I can enter to this and I can remove it. And I can see that that is the fornix, which was also not able to come from transventricular. And that is the way I have tried. And you can see with this strategy, I could remove this completely. And you can see this lady, you can see that was my incision, and the paresis become much better, and the tumor was removed. This is a very important case, and there are a lot of such a case in future. We have to consider this for surgery. That was an 11-year-old boy with large intraventricular lesion, with extension into the corpus callosum and left hemisphere. The left hemisphere under the motor cortex here, as you see here, intraventricular. And the history was very interesting. And here you can see also the part in the under the motor cortex and as anterior to the motor cortex. The history was this 11-year-old boy had tremor and coordination disturbance on the right side, severe cognitive disturbance, significant development retardation at school, and also he suffers from several generalized seizures daily. In EEG, several epileptic spikes, temporoparietal, both sides, under therapy with high dosage of 3 anti-epileptic medication, because biopsy was done and was a diffuse astrocytoma in his homeland. And we know that when the children in an early age, they become so many medication, they remain as a child and they don't develop. And that is something we have seen in many of the children with epilepsy. This is my way how I came to the ventricle, remove the interventricular part, and remove the corpus callosum here where the tumor, and goes up to under the motor cortex, and I could stimulate here, and I had to respond in the leg of the patient. Here you can see again very nicely the different MRI and post-operative neurological examination showed immediately improvement of cognition, and the boy was completely changed in communication, in behavior, and everything, and then significant improvement of tremor and coordination disturbance on the right hand, but no more any generalized seizure, which was very, very important. And post-operative EEG, no epileptic wave, post-operative MRI control, total removal of tumor after 2 years. This is it after 2 years control who came to us, and it is almost now 5 years, and the boy is in school, growing and growing, going further and further. And I think there are a lot of such children, they need our help in future. This using the sulcal approach is, of course, can help us many other processes to use and to treat. This is a large meningioma, which is just under motor cortex, as you see here. And that is the functional MRI. And you can see that here, that is a lady. And we have decided to not go to the midline and remove the tumor which create motor cortex. We have decided to use this sulcus and remove the tumor. And you can see that very nicely we make the craniotomy here. That is the motor cortex. When we come from here, we would destroy that. And here, then you can see that this approach is so simple. Immediately we are in the tumor and we could remove it. And this is the patient post-operative, and you see without having any paresis or any problem. And but we know more than 30% of this patient, when you use the parasagittal in that area exposure to remove such a meningioma, they have a pelagic leg, and in this case, we could save that. I will show you as a last case, in order to keep my time. Of course, I have a lot of other things to show you, but I want to keep my time. This case seems also a case I have asked many neurosurgeons, how would you operate this case? Some say so supratentorial, I could perhaps remove this and this, but this is exactly in front of the lamina quadrigemina, and when you come here, you can destroy that if you want to remove it. If you come from here, also problem. In this case, I have decided also to use a lateral transsulcal approach to this in order to come in the middle here, then I can remove this, and also elevate that and remove that. And so that this happened. You can see the approach, and here the tumor is over 5 centimeters. And now small incision of the sulcus, open the sulcus, come to the tumor, and that is that was a dermoid tumor. And here is one of the dermoid tumor, enucleate, and go to the next, and go to the next, and then finally remove it completely. And here, the tumor is completely removed. And the patient had a Parino syndrome before surgery. This is 3 months later. He had no neurological deficit after this surgery. I wished, here you can do ocular muscle movement. I wished I could continue, because there are so many other things with a brain surgery to tell you, but I think it would then come over a lot of time you have given to me. It was really a pleasure for me to give this lecture and bring some of my experiences with brain surgery. Thank you very much again for inviting me for this lecture. Thank you.
Well, you know, I told you this was a display of Shakespearean talent. A surgeon of this level and this talent comes once in a generation. And as I said before you started the talk, when we talk about literature, we say there was Shakespeare, and there was Cervantes, and then there was Dante. And I think with Professor Samii, we will say there was Harvey Cushing, there was Ghazi Yasagil, and then there was Madjid Samii. So I think he is, just for the younger people, that you're so blessed to listen to somebody that is so incredibly talented and has a wonderful thought process and has been able to motivate neurosurgeons across the world in a way that has made the whole world a safer place with great cases. So not only is he a master surgeon, but he's a great mentor to so many of us across the globe, and he gives his time effortlessly. So we just want to thank him. And also, I always make a point of thanking his wonderful wife. Behind every great man, there's a great woman. And his wife has been wonderful. And of course, his son, Amir, as well.
Thank you so much. Before we open this discussion, we'd like to have a few words from Professor Yoko Kato.
I thank you very much for Madjid Samii. The nice lecture. Very strong. The message from you is never to give up. And also the great some idea and also overlapping of the whole the recent some new techniques. I think it's come to the great success and result. We learned a lot today. Thank you so much, Madjid.
Thank you so much. We can open this topic for discussion. First, may I invite Professor Atul Goel to say a few words.
Professor Samii.
Hi, my dear Atul. Nice to see you, my dear Atul.
Thank you, Professor Samii. Nice to see you after a long time. And the most important thing is to see you so your face is still glowing with charm and with youth. So that is the most important thing. And also the way you are presenting, the way you present that childlike enthusiasm. You know, did you hear that, Professor Samii? Childlike enthusiasm in you still persists. And your vibrant and open mind, always getting new ideas and thinking about it and trying to teach the entire world. Professor Samii, I want to hug you and I love you. Professor Samii, thank you always.
Raja. Professor Isnad, thank you so much.
Professor, great lecture. We enjoyed your lecture. I just want to congratulate you for telling us that in many of these low and high grade glioma, the functional areas are not displaced. You told they are reorganized. It was a very beautiful message you gave. And also you told that in all these, both for high and low grade gliomas, more than 90% of the patients, their functional status is either unchanged or improved. What a great surgery. And you told the importance of trans-sulcal approach for deep-seated tumors and going through sulcus and not going through functional area. My question is, Professor, what are your comments on awake surgery? Or you do only under general anesthesia and do cortical stimulation? That is your technique, or you do awake surgery for gliomas?
Thank you for touching this topic, because I didn't want, because I could give at least talk 5 minutes about the awake surgery to say my opinion, but I didn't want to overcome my time, and that was the reason. I have started, I'm one of the first who started. You can be sure there is nothing that I have not tried to evaluate it is useful or is not useful from beginning. And I have done at least 50 cases, and we have also evaluated awake surgery. And of course, we did with all parameters existing. And once we had the intraoperative MR and we started to use brain mapping and so, and I have seen that by awake surgery, I have to stop many times unnecessarily because I had a response with the stimulation and I had to leave some tumor in place. even it is not it is not right that I am stopping. So, and sometimes even we stimulate, we had a false positive, false negative reaction. And the patient was suffering all the time. Yeah, how do you want that? And finally, I found that the awake surgery is not anymore helping the neurosurgeon to really take care of the different aspects of it. Is for me, I can definitively say, not my hand for patients, nothing. They make the surgery more difficult, the patient suffering during surgery and so on. But my result is now much better for completeness of removal and for preservation. You must imagine that you can, for example, for motor function, when the patient is general anesthesia with intraoperative MR or without intraoperative, when you stimulate, you can then see the reaction of the movement of the extremity without awake surgery, because the anesthesiology must be a little bit not too far with the relaxation of the muscles and so that, and therefore I am thankful to you for this question. Please don't follow this. Some people are over exaggerating. I don't know why the awake surgery.
Thank you, Professor, for your pearls of wisdom. Thank you.
Thank you very much. We have with us Professor Shubin. Professor Shubin would like to say something.
Professor Samii, congratulations. There's almost 2,000 audience in the WeChat channel watched your presentation. And my question is about, do you have some comment on Elon Musk's Neuralink? I mean, to put some probe in the brain. The Neuralink, do you know Elon Musk's project?
For which purposes?
I don't know.
I have to know.
And, can you comment on some AI? Do you have some comment on the AI used in the neurosurgery?
I think I cannot give you any because I am not using that, and this is for me not a very clear situation. And, and I must tell you, I am so happy that that many Chinese neurosurgeons are watching this lecture. As you know, one of the countries that in which I have spent a lot of time and organized so many educational courses, but educational courses, not a theoretical educational course, but always I try to perform live surgery with most difficult cases to show my Chinese colleagues. I think I am very, very happy and also proud that my Chinese colleagues during the last 30 years that I was trying to organize the courses and giving lectures, particularly from Shuangwu Hospital. And every year I had more than 1,000 colleagues coming to me, and please accept my congratulations for the level that today my colleagues, Chinese colleagues, with them are treating the patient. I am very proud of that because that was my goal as I started 30 years ago. And therefore, I believe that every Chinese neurosurgeon belongs to my philosophy on the school, that they are doing the neurosurgery, whatever they are doing. You see, we have this so-called China Union. We have 27 centers in different parts of them that they are connected with me and in Beijing, and we have permanently educational program. And now we have opened the new hospital in Shenzhen, which is also, I have designed it with all equipment which are existing in Hanover. And I hope very much that Beijing and also the Shenzhen both will be a center for education for younger people that they come. I am waiting just that the Corona problem will go over, and the China is now a little bit closed, and with quarantine, with 14, everybody has to spend 2 weeks quarantine, but you can imagine what it means for me, 2 weeks to go to quarantine. I have every day here 1, 2, 3 surgeries, and I cannot go. So, but I hope very much that in the next 3, 4, 5 months, we will have over, and then I will see my colleagues. And I'm very happy that you have tried to connect our Chinese colleagues to this lecture. Thank you very much.
Thank you again for your great achievement in Chinese neurosurgical education. Thank you.
Thank you. Thank you very much. With that, we can close this webinar. Before that, I would like to hear a closing comments from Professor Nanda as well as Professor Yoko Kato. Professor Anil Nanda.
I think we are one family across the globe. And I think every mother and every father loves their children, no matter where you are. And Professor Samii, once again, is like the godfather of neurosurgery. He has reached out across the globe, across religions, across races, across people. And his only focus has been to make this a better planet, to make it a better neurosurgical planet. And for that, we are all indebted to him for his incredible leadership. And I want to thank the Asian Congress for reaching out to everybody across the globe. I think COVID reminded all of us that whether you're rich, whether you're poor, whether you're in a wealthy country, whether you're in a poor country, whether you have resources, we are all prone to the same diseases. And our humanity is the one thing that unites all of us. Thank you very much.
Say a few words before closing. I would like to thank you all, first of all, for creating such a nice environment for our colleagues, neurosurgeons in Asia, particularly India and China, which have both together is, we would say, half the population of the world. And what I would like to mention is, for all technique and all, I would say, innovations I had in my life, you should keep in your mind the patient was in center of my focus. I have never tried to hurt any patient in order to try a new innovation. Before I started to do something, I was convinced that it doesn't hurt the patient, and I will not suffer in my soul that I have done something that my patient is disabled or something happened. And this is something what I would like to emphasize, that everybody who believes he has some idea, he has always to think, if you were the patient, would you then use this idea in the patient or not? And that was always in my life on the highest front of my activities. And because people then say, when he has innovated so many new things, then probably he had a lot of, no, I can say I was convinced when you have seen all these cases that I have done first time, it was working. Because I had planned in my mind, in my brain, that if I go this way, nothing can happen. And if I came and saw that it is not possible, but I didn't try to make it 100% to reach the goal. And this happens sometimes in some place that I am not happy about that, because new innovation should not create problems for patient. It must help the patient for a better future. I'm sorry, because this is very important for young generation. They believe when I start now to do whatever I have in my mind by my patient, I will probably discover the whole world. No, that is nonsense. They do some mistakes and they have to lose or to leave neurosurgery after 3-4 such cases that was not very well planned. That is my advice to young generation. Thank you giving me this opportunity. Thank you again to all of you. Thank you.
Thank you very much for those words of wisdom. I would like to go back to our president, Professor Yoko Kato, for her concluding remarks.
I thank you so much, my dear Professor Samii, for your nice lecture. So today we got the big power from you. I don't know, every time I meet you, I met you. So you gave us so enthusiasm to continue our neurosurgical kind of the work. So I really thank you very much for your the educational lectures tonight. Thank you so much.
Thank you so much.
And Anil, thank you so much. Long life, Professor Samii. Thank you very much.
Thank you. Thank you very much, my dear.
Thank you.
I'd like to close this officially on behalf of the Education Committee of the ACNS and our President, Professor Yoko Kato. I would like to sincerely thank today's speaker, Professor Madjid Samii, who just showed us why he is man ahead of his times. He has contributed so much towards the development of neurosurgery. Thank you so much to Professor Anil Nanda as well for his time and support for us. We had a very exciting session and a lot of learning with both of you. A very special thanks to Professor Yoko Kato and Professor Shubin from China for joining us today. We are extremely thankful to all the distinguished neurosurgeons, Professor Atul Goel, Professor Suresh Nair, and all the others who have joined from all over the world. Regarding the next webinar, I would like to inform you all that it will be on the 12th of June, where we have Professor Kenan Arnautovic from Tennessee, USA, will be talking about cranioorbital and pretemporal approach to orbit. And Professor Fengzhen Jian from China will be talking about atlantoaxial dislocation, treatment, and controversies. This webinar will be chaired by Professor Akihide Kondo and Professor Atul Goel. So until we all meet on the 12th of June, it is bye-bye from all of us. Thank you all for joining. Thank you very much.